All right. Officially, good afternoon, good morning, good evening, and welcome to UCSF Center for Global Nursing's Impact Series. This series aims to provide a platform for our nurses and global partners to share their remarkable work, offer valuable insights, and inspire our global community. Following today's presentation, there'll be a short Q&A, so feel free to write your questions throughout the presentation in the Q&A box below. My name is Dr. Rebecca Silvers. I'm the director of UCSF Center for Global Nursing, and it is my very big pleasure to introduce this month's speakers. We've got Evelyn Bigini and Patricia Efe Azikiwe. Did I mess it up, Patricia? Oh no. I'm so sorry. Who will present their critical research from Sierra Leone. Patricia is the Reproductive, Maternal, Newborn, Child, and Adolescent Health Clinic Program Manager at Partners in Health in the Kono District of Sierra Leone, as well as the focal person for Perinatal Maternal Mental Health at Partners in Health, Sierra Leone. Patricia's work focuses on strengthening maternal and newborn health outcomes through capacity building, mentorship of healthcare providers. Patricia is also recognized as one of the pioneers of Mother-to-Mother Support Initiative in Benin City, Nigeria, an intervention that promotes exclusive breastfeeding through healthcare worker training and community engagement. Evelyn is a PhD candidate here at the UCSF School of Nursing and a graduate student researcher with the UCSF Global Action and Nursing Initiative here at the Institute of Global Health Sciences. Evelyn's work focuses on improving perinatal mental health through partnerships in healthcare organizations such as Partners in Health in Sierra Leone. She brings a strong global health perspective to her research with a master's degree in global health delivery from, I think it's from Maastricht University in the Netherlands, and a master's in from the Global Health Equity, in Global Health Equity, sorry, from the University of Global Health Equity in Rwanda. Throughout her career, Evelyn's been committed to advancing maternal, child, reproductive, mental health through community-centered approaches, and her research explores innovative strategies to improve mental health outcomes for both patients and healthcare providers across the globe. Please join me in welcoming Evelyn and Patricia, who are also our 2025 Center for Global Nursing Research Seed awardees. And we are honored to play a small part in supporting the incredible work that they do. Welcome, Patricia and Evelyn. I'll hand it off to you.
Thanks so much, Rebecca. Let's see. Get this going. Patricia, do you want to get us started? Oh, you're on mute.
Yes. Thank you and good afternoon to you all from Kouédou Government Hospital, Sierra Leone in West Africa. I am pleased to present a study, the provider's perspective on prenatal depression in Kouédou Government Hospital in Sierra Leone. Prenatal depression occurring during pregnancy and childbirth is a major under-recognized public health challenge. It affects not only the mother, but also the newborns, families, and overall community's well-being. Despite its importance, it remains largely underdiagnosed and undertreated, especially in low-resource settings. Our study explores the staff in Kouédou Government Hospital, how they understand, their experience, and respond to prenatal depression, as well as the challenges they face and opportunities to improve care. The background, why this project meets the theme, the research, education, and the results. Under the background and rationale, this project was developed in response to a critical gap. Maternal mental health is essential to quality maternity care, yet prenatal depression remains under-addressed in Sierra Leone. Although maternal and newborn care have improved, mental health, especially during the prenatal period, has received limited attention. Providers, we the nurses, we are central to the issue because we are often the first point of contact. during the postpartum period and during the antenatal period. So our perspectives are therefore very essential in understanding the real world barriers, the opportunities, the identification and management of this condition. The project was implemented by a multidisciplinary team, the research, the education team, and the health services. Going to slide 4, I will hand it over to Evelyn to tell us more. That is the current landscape. Thank you.
Thanks so much, Patricia. So looking at the current landscape of what the literature shows on the mental health of perinatal patients and their clinicians, we see that there are very limited studies from Sierra Leone. However, we see one study showed that almost half of 140 perinatal women experienced psychological distress, and this was verified by themselves and a loved one. Looking at West African research more broadly, we see most of this is actually from Ghana, and that 1 in 3 perinatal women may experience depressive symptoms. However, we see that there's heterogeneity or a variety in how these things are measured, both populations, such as when screening occurs, the antepartum and postpartum period, and when during that time, as well as what scales are used. And so this is important to note because it affects the outcomes. We also know that depression is more studied than anxiety, and this is a finding common across the world, even though we know that oftentimes that these conditions can be comorbid, so people experience them together. Now, as Patricia has been talking about, what about the providers who care for these patients, particularly the nurses and midwives? So one author has actually recommended the ability to have psychological counselors available across the health system to assist both patients and providers, such as through debriefing. And we know that resource stressors, such as lack of staff and equipment, can contribute to stress and even moral distress, which occurs around a specific moral conflict or event. We know that resources are important everywhere, including for perinatal and infant health, both around the world and in the US, for example, such as the recent study in the US on the impact of monetary support in Flint, Michigan on maternal and neonatal outcomes. We also know that it's important to integrate cultural understandings and expressions of mental health, and this has occurred in Sierra Leone, such as looking at idioms of distress and how to adapt task-sharing models to the Sierra Leone context. I'm going to hand it back to Patricia to, in addition to the research, tell a story about what the nurses and midwives see. Oh, you're on mute, Patricia.
Yes, I want to tell you a story of Kadiatu, an 18-year-old first-time mother. After delivering a healthy baby, she was expected to be joyful. However, she became withdrawn, overwhelmed, and emotionally exhausted. She cried in silence, doubted her ability to be a good mother, and struggled to care for her baby. Her family interpreted her symptoms as laziness or spiritual issues, and she did not receive appropriate support. It was only during a visit to the clinic that a midwife asked a simple question about her well-being, and that was the turning point. Kadiatu finally felt seen, and she was able to express her emotional struggles. Her story highlights an important reality. Maternal suffering is often invisible, and without recognition, women may endure depression in silence during a critical period of their life. Next slide, please. Meet the team. We have the nurses and midwives, and we are the frontline clinical experience in maternal care. We have the mental health professionals. They provide expertise in assessment, diagnosis, and the care pathways. The researchers ensured scientific rigors in study design, analysis, and interpretations. Education specialists translated findings into training and capacity building. This collaboration ensured that the work remained both evidence-based and practically relevant to the health system. Next slide. Our bereavement support team. It was established to support families experiencing the loss of a baby or a mother during the prenatal period. The aim is to ensure that families are not left alone during such a traumatic experience. The team provides emotional support, respectful communication, psychological first aid, and linkage to further psychosocial and spiritual care. It is an interdisciplinary team involving nurses, midwives, doctors, mental health professionals, and social support staff. The initiative promotes dignity in loss and strengthens compassion between the patient and the families and patient-centered maternity care. So we support mothers, ensure that we stand with them and educate them on how to feel, give them room to cry, give them shoulder to cry on, and educate them on the next step to take. So the next slide.
Thanks so much, Patricia.
Evelyn.
Thank you. As Patricia has talked about, this project includes both research and education components. So looking at screening across the perinatal time period, as well as what happens with referrals to the mental health team and providers' experiences, as well as education on screening tool use, international certification in perinatal mental health, and continuing professional development sessions. So this diagram in the solid colors specifically shows the current screening and referral process at Koidu Government Hospital. So two depression questions are on a checklist administered upon admission to delivery. And then as well as provider concern across the perinatal period. Both of those can trigger a patient referral to the mental health team, in which they're then screened with longer depression and anxiety scales and provided follow-up care through psychotherapy and medication. Now, looking forward, the project includes adding these two depression questions, which are on the next slide, to antepartum as well as postpartum visits. And then we will be looking at the screening rates as well as risk factors for positive screening. So these are the two questions on the scale and this is an international tool that is used. These two questions are also part of the longer 9-item scale, which has been validated in West Africa. Now, for those viewing this who are nurses yourselves, you might give these questions to patients and even be asked them at your own health visits. So in this study, we're also looking at providers' experiences of caring for patients and impact on their own well-being. So the different research components are interviews and focus groups across maternity wards, as well as zooming in on the NICU specifically, given the importance of family-centered care and the multiple stakeholders involved in the NICU. We will conduct interviews, field observations, as well as policy and curriculum analysis, looking at across Sierra Leone. And we've developed a conceptual model based on different theoretical frameworks, the mental health and psychosocial support framework, eco-social theory, as well as the literature on African understandings of the self and mental health. We have, as a team, created a couple different infographics based on the World Health Organization and National Institutes of Mental Health recommendations for mental health, including focusing on clinician well-being. And this has been adapted to the Sierra Leone context. So this infographic specifically was chosen by the Partners in Health Sierra Leone team and will be on a reference sheet for clinicians participating in the study. Now, in terms of education, we'll be implementing education on using the two items, the two screening tool items, as well as a certification in perinatal mental health for 5 nurses and midwives from Partners in Health Sierra Leone. What this requires is 2 years at least of experience working with perinatal populations. The focus is on perinatal mental health disorders, and then advanced therapy or or pharmacology, excuse me, and then a proctored exam. So this is an international certification focusing on knowledge competency. And then with our educational specialist at GAIN Madhavi, we are also working to use current 6 steps of health professions education curriculum development to identify topics for continuing professional development sessions. Regarding our progress thus far, we're using the analogy of a mango tree, which is very common in Sierra Leone. So it all started with a seed, including the CGN Seed Award, which is the development of this mixed methods study. Patricia came to GAIN a year and a half, 2 years ago, saying we really need to do something about this. So through that, we've developed this mixed methods study, a dissertation project, and educational interventions. Right now, we're growing the tree, so finishing the IRBs, doing our certification exam, as well as for a scoping review and policy and curriculum analysis, which I'll present preliminary findings on. And then finally, we're really looking forward to getting the fruit, which are really the data about what is happening in terms of screening and outcomes, as well as providers' perspectives. So this is a preliminary results from a scoping review about clinicians' mental health in West African neonatal intensive care wards. There is no Sierra Leone specific study, which is a gap that we really want to fill through our project. While this project and the work is interdisciplinary, as Patricia has said, there's limited community and mental health worker perspectives included in the research so far. Mostly studies are qualitative, which are great for understanding overall context. However, there is reflexivity missing, and this is really important because we need to acknowledge who we are as researchers, and people. So how do we affect the research and vice versa? So in my case, for example, I'm not from Sierra Leone. I've been working with the team for some time, but it's really important to have humility about where blind spots are. We also know that staffing, space, and communication challenges can affect provider well-being. There can be moral conflicts, such as discharge against medical device. And very, very importantly, we know that nurses and midwives are also patients and family members. So thinking about all of us, while we are researchers and professionals, we also have our own personal experiences that we bring to our work. Now, what about policies, reports, and curricula? These are different documents that we've looked at about the resources available for clinician mental health. So the resources are a lot of government interest, as Patricia will talk about on the next slide. Strong partnerships between partners in Sierra Leone and across the world. Rolled out psychological first aid training from the government as well as the World Health Organization. There's a lot of motivation, clearly, from providers to focus on this topic in both at Koidu Government Hospital as well as people have been asking for trainings in different districts, which Patricia can also talk about more about. There's a cultural lens on mental health in current research and practice, really wanting to focus on the specific Sierra Leone context. However, there's also many calls for more resources, focusing on staff, supplies, trainings, in the context of the effects of the civil war in Sierra Leone, Ebola, national disasters, and COVID-19, as well as persisting gender inequities that the team is addressing. So now I will turn to Patricia to talk about the impact of the project so far.
Yeah, thank you. This project has already contributed to significant changes in both national and educational level. One major achievement is inclusion of the prenatal mental health in the national nursing and midwifery curriculum, with implementation beginning this October. This ensures that future health professionals will be prepared to identify and respond to maternal mental health in Sierra Leone. So, in addition, the study is among the first in Sierra Leone to focus specifically on providers' perspective on prenatal mental health, filling a major evidence gap. The findings provide important insights that can inform policy, strengthen training programs, and guide future interventions. Overall, the project demonstrates how research can directly influence education and health system strengthening, leading to sustainable improvement in maternal and mental health. Thank you.
And we want to thank our acknowledgements for the whole Partners in Health Sierra Leone team. We wish, they were all here talking and celebrating with us. We want to thank our funders, my dissertation committee here at UCSF, as well as scientific advising, including from Sierra Leone. Now, thank you so much. And I think that takes us to the questions and answers.
Yes, thank you so much, Evelyn and Patricia. It's really exciting to see this work getting moving with your leadership. I think it's filling a gap that you've clearly identified and a large need for the community. Let me check and see if there's any questions in the Q&A box. Otherwise, I'm happy to start it off. But yeah, I don't see any. Do you guys? Nope, I don't see any. I think my first question that comes to my mind is what gave you the inspiration to not just focus on patients and families, but also providers? I think so often we don't think about, I've been a nurse for more than 20 years and a nurse practitioner, and I work in critical care. So I've seen quite a few things. And I don't know. If there's been as much thought about what we experience as providers and the things that we see. And it's really exciting for me to see that you're looking at it from two different angles to really understand the whole concept across kind of the continuum of people in this maternal child space. I would love to hear more about your ideas around it, your inspiration. Yeah, I would just love to hear more.
Yeah, thank you so much. Our facility, Kwetu Government Hospital, is located in the eastern part of Sierra Leone, and it is the only CMOC facility covering a population of over 700 people, majority within the child reproductive age. And this facility receives referral from over 109 primary healthcare centers. On daily basis, we see mothers coming in from far districts and from neighboring countries, coming in a critical condition, and we nurses and midwives will manage them. At the end, it's either they die or they lose their babies. And at the end, we see husbands crying like newborn babies. We see relatives jumping up, throwing themselves up and down, crying. Then my nurses and midwives, they go to one corner and they start crying too. And I say, look, if we cry more than the bereaved, how do we not comfort them? And most of them started having mental health issues that, enabled me to now say, look, something has to be done differently here. If not, I have all of them having issues with mental health. And that was how we started. Not only attending to the patient themselves, but attending to the nurses that cared for these patients. So that was how the inspiration started. Thank you.
Wow, yeah, that resonated a lot with me in my career in pediatric critical care. And I was just working with partners at a level 6 hospital in Kenya, and they said by the time the children arrive here to our emergency room, they're whenever they have a code event, they're always dying because they're so sick when they arrive, and that's really distressing and that's really hard for us to continue to witness these families losing their babies or and they feel really helpless because as nurses, our desires are to help and to improve the health and well-being. And I could see how that would really that we need some attention in this area. And it's really important that we put that focus there. Um, I wondered, do you guys have I'm really excited to have you guys back once you guys have your mangoes. I really loved the analogy of planting the seed, growing the tree, and it really shows how the many steps it takes to complete a really important research project that you guys are doing and all the steps necessary. And then love that you highlighted the side things that are happening as a result of just even the momentum of the project. But do you have a timeline for when you guys hope to move all the steps forward for your project? Is that something you guys have been kind of calculating and thinking around?
Yeah, thanks so much, Rebecca. We actually have gone through, Patricia knows, many versions of getting the IRBs together, but we hope that they are approved in actually the next month or two in Sierra Leone. And we have UCSF approval already, so hoping, it's June, August, September, October that we're, yeah, really getting moving on this. The team is very, very excited and really pushing for it.
That's wonderful and amazing. We do have one question um, in the chat from Fumi. How has the community received this program without the cultural barriers around mental health in this part of the world?
Yeah, thank you. Very, very well received. That now we now work with stakeholders, the community leaders, market women. We have the religious people amongst our team, both from the Muslim area and the Christian area.
Mm.
And like yesterday, a community member reached out to us that we should come and take care of a woman that delivered
Mm.
and now exhibit showing signs of mental health problem. So immediately my team went there and brought the woman to the hospital. So we now have that forum where we now have TBAs, traditional birth attendants, as our members. So they work in the communities. So they reach out to these mothers, refer them, bring them to the hospital for us to manage.
Mm.
And this project has really opened our eyes
Mm.
to see that maternal mental health is on the increase in
Mm.
Sierra Leone. It is very well received, not only in our facility and our community. Others in Freetown, the capital, are waiting for us to
Mm.
come and teach them what we are doing so that they start it. It is everywhere. So
Mm.
more people are coming in, communities are joining us to ensure that we manage it and manage it properly. Thank you.
Thanks, Patricia. I wonder, is there any stigma? I know I've worked in some parts of the world where mental health has a lot of stigma. Is that something that's experienced in Sierra Leone?
Oh, yes. And that is why they don't speak out.
Mm.
They don't speak out. Once it starts, they attribute it to spiritual issues.
Mm.
They hide the mother at home, chain her two hands and two legs. At times they flog them.
Mm.
Yes. So, but since we started going on we go to the radios
Okay.
yes, we go to the radios, we go to the churches
Mm.
to talk to them. So telling them that this should not be. You bring them, you call us, that
Mm.
we can handle them. So
Mm.
that is why people are now coming out and now reaching out for us to come and help them out when they have such a case at home. Yeah.
Wow, that's it's incredible. I think it's really hard to overcome stigma and barriers to to receiving mental health services. I know there's a lot of communities that really are working towards what you're doing. So hearing some of your strategies, I think is really inspiring and really helpful. Just really reaching out to the community in ways where they feel safe to engage in asking for help and for you to have the services to provide the help. It's just really inspiring. So I know we've reached time. I just want to thank our community for joining today. I want to thank Evelyn and Patricia for sharing their remarkable work and where it is thus far, and thank them for their incredible contributions and the impact that they're making already. And it's really remarkable, and your leadership is really inspiring. So thank you so much for joining us today. And we look forward to hearing the outcomes of this study. Thank you so much.
Thank you, everyone. Thanks so much.
Thank you. Thank you, everyone. Bye.